Hello, everyone, and welcome to today's MIPS Tips session, MIPS in a COVID-19 world. I am Sharon Phelps, Senior Account Manager for the Quality Payment Support Team at Mountain Pacific Quality Health, and I want to thank you for spending a few moments with us today. MIPS Tips, next slide, please, Miranda. MIPS Tips is a collaborative effort among three organizations, the Network for Regional Health Improvement, Comagine Health, and Mountain Pacific Quality Health. Our goal is to provide clinics and clinicians timely information on the quality payment program and to give you a chance to ask your questions related to this program. Comagine Health and Mountain Pacific support practices in a number of states, as shown on this slide. We will provide you with contact information for each state at the end of today's presentation. Next slide, please. First, we're going to talk about a few housekeeping details. I would like you to locate the chat feature in this webinar platform, as we will be posting links to resources throughout the webinar today. And our first resource is coming up or has already been posted, and that is the link to today's slide deck. So if you're one of those folks who likes to take notes or have a copy of the slide deck, you can download that copy right now to follow along. This webinar is being recorded. For all who have registered, we are sharing the resource links, a link to the recording of the webinar, and a copy of the slides in a follow-up following the webinar in an email. Additionally, those items will be available on the Comagine Health and Mountain Pacific websites. You can find slide decks and recordings from our prior MIPS tips, along with a lot of valuable resources out there, so please visit our website. Next, I want to thank everybody who sent us questions before this session. We had a number of questions, and they were very good questions. So as we go along today, Miranda is going to address those. We invite you to use the chat box to enter any additional questions for the moderated Q&A portion of this webinar, or if we only glance and answer your question kind of from the side and you need more information, just throw that in the chat box and we'll get to that. In addition to providing you with information and answering your questions today, we also really want to gather information from you. Each month, we have the opportunity to meet with a representative from CMS, where we report on the work that we're doing and we provide them with feedback from the clinics and clinicians with whom we work. Providing this feedback is more important than ever now due to the wholesale disruption of healthcare due to the COVID-19 pandemic. We want to ensure we are representing your voice and passing along your input to CMS as they review potential flexibilities for 2020 MIPS. We invite you to provide your input in chat as well as in the moderated Q&A session. And we are also going to do a few short polls to gather some information. So Nat, can you please post our first set of poll questions? Okay, I can see that popped up. We're going to give everybody just a minute or two. You're going to want to scroll down. There is 4 questions total in the poll box. Let's give that about another 10 seconds or so, Nat. Probably maybe a little more than that since there's 4 questions. So what we're asking in our poll is, has COVID changed your 2020 MIPS plan at all? And if so, we kind of came up with a few ways how it could have changed. If it has changed and none of our options fit it, please click other and then put those changes into the chat box for us. And then the other 2 questions are pertaining to telehealth, because we're going to talk just a little bit about telehealth later in the session. So, okay, Nat, how are we doing for getting those results?
I'm just starting to see a few get entered into the last question, so I'll give just maybe 10 more seconds and then I'm going to close this out.
Okay. Yeah, it probably takes a little bit since there's 4 questions in that poll. Okay, while you watch for that, Nat, I'm going to go ahead and introduce our speaker. Our speaker today is Miranda Brzezinski. Miranda joins us from the Anchorage office of Mountain Pacific. Miranda joined Mountain Pacific in 2017 and is currently the task lead for the QPP work for the small and rural clinics. Her work has included working with clinics and clinicians on improving cardiac health and chronic disease, adult immunizations, as well as work in the quality payment program. Miranda conducts quality improvement activities with clinicians and medical staff, facilities, and stakeholders to improve patient outcomes. She works across multiple states to identify opportunities to improve our reach. She works on tools and resources for technical assistance. She also provides MIPS support to providers in Alaska, Hawaii, Montana, and Wyoming. Okay, thank you, Nat. So it looks like just over half of the folks report that the pandemic has changed their plans. And it looks like we're going to be seeing some stuff in chat on what they're going to be doing differently. So we'll take a look at that and you can all see what people are entering in chat. Okay, now let's look at telehealth. Wow, 87% of folks are performing telehealth, and it looks like 80% of those did not use telehealth before. So everybody's been on a pretty steep learning curve with telehealth. Thank you for those results. And Miranda, I am turning it over to you.
Thank you, Sharon. Okay, so today, first I want to thank everybody for attending today. We had hoped that we would have new guidance from CMS for any changes to MIPS 2020 in light of the COVID pandemic by the time of this webinar, but unfortunately they've not released anything as of yet. So I want to assure you that we are monitoring daily all the releases from CMS for possible changes for MIPS 2020, and we will in turn notify you as soon as we see anything. So later in the presentation, you will see where you can provide us with some information and we can get you signed up for our listservs. So that way you're receiving emails that have very timely changes to MIPS or information concerning the merit-based incentive payment system. So in lieu of not having any real changes to MIPS due to COVID, today we're going to start with an overview of eligibility criteria and the program requirements for 2020. Next, we're going to move on to important timelines and dates, as well as resources and where you can find them. But the majority of this webinar is going to be focusing on live questions and answers. We had quite a few questions submitted to us on the registration forms for this MIPS tips. We took those and tried to group them as best we could so we can answer them during the presentation. But if we missed your question or you come up with new ones, feel free to put them in chat. We have team members monitoring the chat box, and so they can respond to you, or you can wait until we get to the live question and answer segment, and then you can ask your questions then. We also want to gather some questions and statements that you would like for us to send to CMS. We thought it might be time for us to get some information from the providers on the provider level and go ahead and send that off to CMS so they can see directly how MIPS is impacting the clinics and clinicians on the ground level. So we're going to start with determination today. So CMS determines if a clinician is eligible for MIPS each year. I want to point out that for 2020, there are no new clinician types added, but there were 6 new types added in 2019, and those included physical therapists, occupational therapists, clinical psychologist, qualified speech language pathologist, qualified audiologists, and registered dietitians or nutrition professionals. So what's important about that is before you can even begin to determine if you are MIPS eligible, you have to be one of those MIPS eligible clinician types that are listed right there. So if you're a MIPS eligible clinician type, we're going to move on to the low volume threshold criteria. I'll come back to the determination periods in just a second. But to be considered eligible, you must meet or exceed all 3 of the low volume threshold requirements for both determination periods to be eligible for MIPS. The low volume threshold criteria are you have to have billed $90,000 or more in Medicare Part B charges, see 200 or more Medicare Part B beneficiaries. And in 2019, they added a third criteria, which is you must provide 200 or more covered professional services to Part B enrolled individuals. So back to the determination periods. The determination periods are also referred to as Run 1 and Run 2. Run 1, or the first determination period for 2020, is October 1st, 2018 to September 30th, 2019. And Run 2, or the second determination period, is October 1st, 2019 to September 30th, 2020. I want to point out that Run 2 of 2020 is also the first determination period of MIPS 2021. Likewise, Run 1 of MIPS 2020 was the second determination period of MIPS 2019. So to be considered truly eligible for MIPS in a calendar year, an eligible condition type must meet the low volume threshold in both determination periods. This is why when you use the participation status tool at the qpp.cms.gov website, you will see a disclaimer box before any eligibility information that says MIPS eligibility will be finalized in November 2020. This is because CMS has to verify that the clinician was eligible in both determination periods. And as you can see, that second determination period doesn't close until September 30th, 2020. So at this time, we're not sure how COVID is going to affect eligibility in 2020. That's part of the reason why I spent so much time on this slide. So with COVID causing temporary closures to some medical offices or changing the capacity for seeing patients, this will influence the low volume threshold numbers for some clinicians. So that is something that you want to think about. If you have further questions about how this may affect you, both Comagine and Mountain Pacific would be happy to set up a meeting with you so that we can go over information specific to your clinic to get a rough idea of how your eligibility may be looking. So the performance periods for each MIPS category and the performance category weights have stayed the same from performance year 2019 to performance year 2020. Quality is 45% of your total score, cost is 15%, improvement activities is 15%, and promoting interoperability is 25%. At this time, both quality and cost categories are reported for 12 months, and improvement activities and promoting interoperability are reported for a continuous 90-day period. Know that you can choose any 90-day period that gives you the best score, and the 90-day periods for improvement activities and PI do not have to be the same. Now, I want to also add, with the 12 months category and 12-month cost performance period, with COVID, there could be some potential changes to that due to the disruption at the beginning of this year for service to patients. So just keep that in mind. Excuse me. So the weight for the quality category is 45% of your final score. You're required to report 6 measures with at least 1 outcome or high priority measure. Each measure is scored on a point value of 1 to 10 for a total of 60 points to earn the full 45% weight of the category. In order to achieve data completeness, the provider must report on 70% of applicable patients. So when looking at the measure specification guides of your selected measures, know what makes the patient eligible for your quality measure and be sure to properly document or capture that patient. You may also need to speak to your EHR or registry to confirm your chosen measure is a measure they track. I do want to point out that in 2019 for data completeness, you had to report on 60% of your applicable patients. This year it is now 70. You have to have a minimum of 20 unique patients to be able to report on a measure. The measures must have a benchmark if you want to get more than just 3 points. If the chosen measure does not have a benchmark, you will only receive 3 points for that measure. And then if data completeness is not met, large clinics will only receive 1 point, and a large clinic is considered to be a clinic that has 16 or more NPIs associated with the TIN. And then you will receive 1 point. And if you're a small clinic, which is a clinic that has 15 or fewer NPIs associated with the TIN, you would receive 3 points. So under the more information tab here on the slide, it will actually take you to the CMS 2020 Quality Performance Category Quick Start Guide. So if you want to read more about the quality category, you can look there. So there's multiple reporting types for the quality category. So the collection types are electronic clinical quality measures, which is the ECQMs, MIPS clinical quality measures, which is the CQMs, qualified clinical data registry, which is the QCDR, Medicare Part B claim submissions, which is only allowed for CSRS clinics, so that's the 15 or smaller or 15 or less NPI associated with the TIN. There's the CMS web interface, but that requires a group of a minimum of 25 NPIs. Then there's the consumer assessment and healthcare provider and systems, which is CAPS for MIPS. So important thing to remember is to check your quality measure list to ensure that your selected measures are still in the program if you report the same measures from year to year. So as you can see, for 2020, there's 3 new measures added and there was 42 measures removed. CMS is removing topped out, low value, and low priority measures. And CMS is also increasing the emphasis on outcome measures over time. Under the More Information tab here on this slide, you'll find a document from CMS which goes into more depth on the quality measures added and removed and which collection type may be affected by these changes. So when you see that that has removed and you have the numbers that are associated with the quality measure, that doesn't necessarily mean that that's removed for all 6 of the quality types that I mentioned above. So that's why you might want to take a look at that document and just check and make sure that the measures that you are reporting on are still eligible. All right, so on to improvement activities. This category is worth 15% of your total score. There's one notable change to the improvement activity category this year. Previously, when you were reporting improvement activities as a group, only one provider or NPI had to complete the improvement activity for the entire group to get credit. Now they're requiring that 50% or more of the group complete the same improvement activity during the same 90-day period for the whole group to get credit for that improvement activity. You must achieve 40 points to receive a full 15% weight for this category. So as you can see, the activity weights, medium is 10 points, and that's for a large clinic, and a high weighted activity is 20 points. But selected groups get double points for improvement activities, and small practices, which is again the 15 or fewer NPIs per 10, actually get double points. So as you can see there, a medium weighted would be 20 points and a high weighted would be 40 points. So to achieve the 40 points to get the full credit for improvement activities, a small clinic would only have to do 1 high weighted improvement activity. So I did want to bring to your attention that there is a new improvement activity that was added concerning COVID-19. And right there you can see what the measure is if you wanted to look it up on the qpp.cms.gov website under improvement activities. But the idea is that it promotes participation in COVID-19 clinical trials and reporting COVID-19 related care data to a clinical data repository or clinical data registry for the duration of their study. There should be a link in the chat that will have the specification guide for that new improvement activity. So if you wanted to look further into that, or you're thinking about completing it for 2020, you'll have the information there. And the improvement activities are reported for, again, a continuous 90-day period. And I just wanted to note that your 90-day period can be different from your promoting operability. You're not required to do the same 90-day for both the promoting operability and improvement activity. And again, here is the CMS 2020 improvement activity quick start guide. So I'd recommend looking that over if you had more questions about this category. Excuse me. So next we're moving on to promoting interoperability. So this is 25% of your total score. It's important that you know that you must use the 2015 edition CERT, which is Certified Electronic Health Record Technology. Promoting interoperability moved to a performance-based scoring. So each measure will be scored based on the numerator and denominator or a yes/no response. There are now 4 objectives in promoting interoperability. That would be e-prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. All 4 objectives must be reported to receive a score. There are unscored requirements for the promoting interoperability category as well. If you do not attest yes to all the unscored but required elements for promoting interoperability, you will receive a 0 for the entire category, even if you fully complete all the objectives. New this year is that the PI hardship, which is a form that comes, our application that comes out usually midsummer, and it would be posted on the qpp.cms.gov website. Well, they have moved the location of that to the QPP portal. So previously the application would be open, you would find a link on the qpp.cms.gov website. Now you actually have to sign in to your portal to complete the application, to be exempt from having to report the promoting interoperability. Excuse me. So the hardship application that we were just talking about that is in the QPP portal, you can see some of the people that are eligible. So MIPS eligible clinicians and small practices. So just by being a small practice, you are eligible to opt out of the promoting interoperability category. You don't have to have any further excuse or reasoning, but just the fact that you're a small practice. And as you can see, there's also MIPS ECs using decertified EHR technology, insufficient internet connectivity, extremely uncontrollable circumstances, lack of control over availability of cert. So there are some people that are, some clinicians are automatically rated due to special status. And where you can find your special statuses is when you go to the qpp.cms.gov website and you look under participation status, they will tell you your specialty status is there. So if you choose to opt out of the promoting interoperability category, your score will be reweighted to the quality category. So if the promoting interoperability reweighted to the quality category, quality will now become worth 70% of your total score for MIPS. And I just wanted to note there that you can receive a 5-point bonus for testing yes to the optional measure of query the participation or the, prescription drug monitoring program. So there's always perks for that. But again, here's the 2020 Promoting Interoperability Quick Start Guide from CMS. So if you want to click on that link, you can go ahead and read more about the category. So cost. Cost is worth 15% of your total MIPS score. I'll be the first to admit that the cost category is not my most knowledgeable subject for MIPS. So I'm basically going to read these two slides to you. I want to note that the second cost slide, there's a link to the CMS's 2020 cost quick start guide. I'd recommend looking it over if you have further questions. If you have questions after I read the slides, we do have our resident cost category guru on the webinar, Sharon Phelps, and she'll be able to step in and answer any questions you may have on this category. So weight, it's 15% of your entire MIPS score. You're scored on 2 global measures in performance, total per capita cost per beneficiary, and then the Medicare spending per beneficiary. Sorry, let me grab a drink real fast. Okay, so the performance year 2019 added 8 new episode-based measures, and in 2020 there was 10 added. So if you would like, there's actually a list of all 18 of the measures that we can email you if you let us know in the chat. If you only measure, or if you can only be measured once, if only one measure can be scored, that score will be the performance category score. If no measure can be scored, the cost category weight is added to the quality category. So if that happens, then the quality category will now be 60% of the total score. So if you think back to when we had the promoting interoperability category, and that was able to be reweighted to quality as well. So if both cost and PI are reweighted to quality, that would make quality category worth 85% of your total MIPS score. So the moral of this scenario is to pay special attention to your quality scores because it could be worth a lot of your total MIPS score. So back to here, he must submit quality improvement activity or promoting interoperability to receive a cost score. CMS is the one that calculates your cost score, so it's done behind the scenes. You will not actually have to interactively do anything with it. Cost means Medicare allowed amount, so Medicare payments plus the beneficiary deductible and coinsurance, the traditional fee-for-service claims. So no improvement score, I'm not quite really clear on what that means, but I'm sure Sharon could step in and say. And then again, here's the 2020 cost quick start guide, which I'd recommend reading over because I did very poorly there at educating you on that actual category. So are there any questions for Sharon at this time? Okay, we'll move on. So on to timeline and important dates. So January 1st, 2020, that's when you start your MIPS data collection for quality, and that's when CMS will start the data collection for your cost category. In summer 2020, that's when that promoting interoperability hardship exception application appears. And again, this year it's going to be in the QPP portal, not on the main page. On October 3rd, 2020, that's going to be the last day that you can start a 90-day reporting period for both the promoting interoperability and improvement activities. On September 30th, 2020, the second determination period will end. So like we had mentioned before, the final eligibility should be announced later in 2020. Sometimes it's as late as December, sometimes it's as early as in November. December 31st is the last day of collecting data, and it's the last day to apply for the promoting interoperability hardship. So you want to keep that in mind, that if you are going to apply for that, you can apply for it past December 31st. And then roughly January 1st to March 31st will be your data submission reporting period in 21. So we wanted to go over a little bit of the resources. So I'm sure you've heard me mention multiple times this qpp.cms.gov website. So this is where all the information CMS has for MIPS, and this is where it's stored. So as you can see in this picture, which is a little distorted, but do you see that top where it says update and it talks about COVID? This is where you're going to want to land to find out any kind of new information that's happening or updates that are going on with the program. As you can see in the teal box where it has the submission window has closed, a lot of times throughout the year, that teal box will highlight a different event. It will either say like the submission period has started, or eligibility is now available to check, or if there's going to be some kind of changes about COVID, they'll potentially put it in that box. So that's why it's always important to come to this website frequently, regularly, and consistently. So I'm sure you guys have read through the slides, so who should have access? So what we're talking about now is the sign-in. So over on the right-hand side of the picture, you can see where it says sign-in. This is the portal for your specific clinic, your TIN. So this is where you go to check your MIPS eligibility, to submit your data, to view your scores, to routinely check for any changes to your scores, and to capture screenshots for your audit documentation. Okay, I cannot recommend enough the CMS resource library. In previous years, the information they put out was not always helpful, but recently, I'd say starting probably about 2019, they have developed more robust and fully developed resources. You can find the resource library at the qpp.cms.gov, the same place where you find the QPP portal. Just click on the upper right-hand corner where it says, where you can navigate to the resource library. As you search the library, you can find more specific resources as shown on the image that got cut off a little bit, so sorry about that. But you can search by performance year, which will be 17, 18, 19, 20, or all. By overview, which is the PI category. I'm sorry, QPP reporting track, which is APMs, MIPS, or all. Performance category, which is cost, improvement activity, overview, promoting interoperability, quality, or all. And then finally, the resource type fact sheets. Resource type, which are fact sheets, measure specification and benchmarks, specialty guides, and technical assistance and user guides, videos, and all. So we have this graphic here because we want to show you how important it is to get to this website and to log into your data. So this is kind of like the wheel of life here when it comes to MIPS, because you need to check your eligibility of the associated clinicians that you have. You want to submit and confirm your data. You want to review final performance scores. You want to review payment adjustments that you might potentially get. You want to review volume and threshold and data, practice data. That's all going to be in the portal for your practice. And as of this year, they're putting that promoting interoperability application exception wave into the portal this year. So more and more things are starting to move to the portal as opposed to just email notifications or website notifications. So it's important that people in your practice have access in case there's overturn of employees, or if the doctor doesn't have time, you want to make sure that at least 2 to 3 people have access to this portal for your clinic to make sure that your data is available at all times. So now we're going to move on to COVID-19, some items of interest. And at this point in time, Sharon's going to take over for this.
Thank you, Miranda. As Miranda mentioned at the beginning of the presentation, there has been nothing released from CMS specifically addressing flexibilities for the 2020 MIPS program in response to the COVID-19 pandemic. There were some changes for 2019 MIPS, such as pushing the deadline back for submission by 30 days, but we've not seen anything specific for 2020. We do anticipate sooner or later CMS is going to give us something on that. There's going to be at least something from them, but we have not seen it yet. However, there is a general area where there are changes due to COVID-19 that affect clinics, and that's waivers. Waivers, the president may, under the authority of the Stafford Disaster Relief and Emergency Act, he or she can declare a major disaster or emergency if they are asked by the governor of an affected state, and if the event is beyond the combined response capabilities of the state and affected local governments. Once there is a presidential declaration, the Department of Health and Human Services may, under the Public Health Service Act, declare a public health emergency exists in the affected state. We have typically seen this before for things like hurricanes. That's probably the most common times we've seen it. We've seen it at times for tornadoes. This is the first time in history that all 50 states and territories are covered under the same public health emergency. So now that we have a public health emergency in place, the Section 1135 of the Social Security Act authorizes the HHS secretary to temporarily modify or waive certain Medicare, Medicaid, Children's Health Insurance Program, and HIPAA requirements that are normally in effect. These waivers and flexibilities help hospitals, providers, and other healthcare facilities give timely care to as many people who have been affected as possible. That means the federal government is attempting to help states and territories to make sure people with Medicare, Medicaid continue to have access to care. Now, for the COVID-19 pandemic, the waivers that have been issued are retroactive back to March 1st of 2020. The waivers end when the emergency's declaration ends or whatever date that the HHS secretary may put into place. Because we are still in this pandemic, and Lord knows we'd all like to know when its official end date is, but we don't. So we don't have an end date, so we don't know when the waivers are going to end. The other important thing to know is there is a huge amount of speculation and wish by a number of folks that some of these waivers become permanent and that regulation is removed forever. And I'll talk about telehealth in relation to that in just a minute. It's important to note that waivers don't offer grants or financial assistance. They don't allow you to be paid for services that aren't usually covered or for people that aren't usually eligible for Medicare. Once your waiver is approved, as always, to be reimbursed accurately, be sure to keep careful records about the services you provided and the beneficiaries you provided them to. So there's a couple different types of waivers. One of them is a blanket waiver. Blanket waivers are issued by CMS. They cover broadly whatever that waiver covers. They cover it broadly, and the providers do not need to apply for a specific waiver for their practice. There are a number, every single state out there has now applied for state-specific waivers. Usually those state-specific waivers are covering Medicaid and what Medicaid is going to be doing differently during this pandemic. And the CMS is continuing to issue those waivers as the pandemic drags on. So a really important key, which I hit just a minute ago, is that if you are operating under a waiver, and at the beginning, the poll question we asked about telehealth, there was a whole bunch of you that had not done telehealth before, and now you are doing telehealth. And whether or not you're doing it now because a waiver allows you to do that or not, stay alert for if and when we see those waivers changing. I wish I could give you a date and exactly what that's going to be, but I don't have that crystal ball. The best place to find those answers is I have a link here to the coronavirus waiver webpage from CMS. If you scroll through that, you'll note that there's dozens of fact sheets on what waivers have been issued. And there is one that specifically applies to physicians and other practitioners. And they updated it on April 30 to incorporate anything new. And I would not be one bit surprised if we don't see them updated again at the end of May or sometime into June. So waivers, we've never really had a situation where everybody's been under a bunch of waivers before, but we do now. Okay, next slide, please, Miranda. Without a doubt, I think the waiver that probably affects clinics and clinicians, physicians, and other providers the most is the telehealth. There have been a huge number of waivers issued regarding the use and the payment of telehealth, including telephonic visits. So be sure you know make sure there was a recent one put out for telephone visits where the payment was significantly increased. It was increased to parity with, I believe, a face-to-face visit or with a telehealth visit. So make sure you check that and you're staying on top of that. This webinar is not long enough to go into all of that, but I know CoMagin as well as Mountain Pacific, we now have information on our websites, and we are actively helping clinics that have questions or issues or concerns with telehealth to help you to be able to continue to provide care to your patients. The other thing to know about telehealth is that if you dig deep into the specifications for selected quality measures, you will find that sometimes they exclude telehealth visits. So when you look at your MIPS program and you look at your quality measures and you're tracking those, you're going to want to know if you're providing a lot of your visits now via telehealth, how that is going to affect that measure. And specifically, if telehealth is excluded in that measure, are you now in trouble of data completeness because you're doing telehealth visits instead of face-to-face visits? So you may want to check your dashboard, and you may want to check with your EHR vendor to find out if the specific measures you're working on are affected by you doing telehealth or not. Because certainly we're seeing telehealth occur in areas where we never considered it would occur before. So I honestly don't know how many vendors were aware of those telehealth impacts on the measures. So that's something that you can do in regards to COVID and MIPS. Okay, I think that's all I have for those two items. So Miranda, back to you. Thank you.
Thank you, Sharon. Okay, as I had mentioned earlier, we do try to get out newsletters and email blasts on timely information or emerging situations such as changes to MIPS due to COVID. So if you'd like for us to put you onto our listserv to make sure that you're not missing those emails, you can contact us at Mountain Pacific through the link that's on the slide here, or you can email me personally. I did want to let you know that if you're going to email me personally, to be signed up for the updates, please include your name, the name of your clinic or your provider, or both, and a good contact number for us to be able to reach you. And then also for CoMagin, if you'd like to be in one of the CoMagin states, you can go ahead and click on that link as well to be added to the list. So now we're going to move on to some of the questions that were submitted to us via the registrations for this webinar. Again, there were quite a few questions, and so we tried to link them into like categories. So if you missed your question, don't worry, you can still ask us. But if this is one of your questions, I hope we're able to answer it enough for you. So one of the questions is, what changes to MIPS for 2020 due to COVID? Again, there currently aren't any, but we are continually monitoring for changes. What changes are in store for 2020 reporting requirements? So currently, again, there are none, and we are watching for any changes. Someone wanted to know how to get the neutral score. So for this year, it's 45 points to be able to get that neutral benchmark where you will not be assessed a negative penalty. We actually have a very in-depth document on our website that tells you step by step what you need to report in order to just get that minimum score if you don't want to fully participate in the program. And so the link is right here on the slide, and I would highly recommend looking that over if you've decided that for 2020 you just do not feel like doing the full participation, but you want to make sure that you avoid the negative impacts. Another question is, how does budget neutrality and payment adjustment works? So as you can see on this little table here, depending on what your score is for 2020, you can see that you'll get a negative adjustment if you get between 0 and 11.25 points. That means that you have to pay that adjustment into the bucket. So we're going to call it the money bucket, okay? So from 11.26 to 44.99, you'll get a negative adjustment between 0.01 and 8.99. So not quite that 9%, but if you can't fully participate, the more points that you can possibly get, the better it's going to be. And then 45 is that neutral benchmark that we talked about earlier. So if you get between 45.01 and 84.99, you'll get a positive adjustment to your reimbursement rates for Medicare billed services of 0.1 to 9%. And then if you are a high achiever or exceptional performance, it's 85.01 to 100. And then you will get, again, the positive between 0.01 and 9%. Plus you'll get a 0.5% exceptional performance bonus. So as you can tell, how this whole bucket is achieved is the negative, or people who don't participate, pay into the bucket. There is already a bucket of money in there, and then the people that achieve higher scores get the positive reimbursement. So now when we say that you could get up to 9% payback, we're not seeing returns that high. They are significantly lower than that because the people that pay into the bucket cannot fund a full 9% to the high performers. So that's why they let you know that it's going to be positive between 0.01% and 9. I believe the highest that we've seen so far is about a 2.35, but don't quote me on that. I believe that's the highest that we've seen. What should we be doing now? So now you should be tracking your quality measures. You should be working with your EHR or your QCDR or qualified registry or your billers who are in-house to make sure that your chosen measures are being tracked properly. You also want to be logging into the QPB portal regularly to monitor for updates, changes, or any messages that CMS is putting out about MIPS. So has MIPS made a difference in the quality of care that's being delivered? So CMS is still analyzing the data that they've gathered. They have not shared with us if there's been any improvement. All that we have seen so far is things like scoring trends and then general data. So we're still waiting for them to put out any kind of information like that. So how does MIPS and telehealth work? So telehealth does not change MIPS. Certain quality measures, as Sharon said earlier, are excluded from telehealth visits. So you want to make sure that you've chosen measures that fall into the category, or if you are, if you are mainly doing telehealth medicine at this point in time, you want to really look at your measure specification guides for quality to make sure that what you have chosen actually falls, telehealth will count and fall into your numerator. So are there any changes to group reporting? The only change that has happened to group reporting is in the improvement activity, and that is that the 50% of the group must complete the same improvement activity during the same time frame. And then will there be an extension due to the pandemic? And it says at this time, we have not heard of any, but we are monitoring the situation and we will let you know. So again, it's important if you're not signed up for our newsletters that you give us that information and go to the 2 links that we had on the earlier slide. So that way we can make sure that you are getting information from us as we get it. So now we are going to move on to the live question and answer section. I'm going to ask Nat to come on and explain how that's going to work for everyone. So I'll turn it over to you, Nat.
Yes, thank you so much. All attendees, you can ask questions if you have any questions about the presentation or any questions from registration that weren't covered. We are also happy to unmute you and you can ask your question live if you'd like. I just need to know that you're willing to be taken off mute. So please chat that in right now and I will make sure that you get on air with our knowledgeable presenters. While we wait for those questions to come in, I did want to call on Monica Gabby. You had a question about COVID registry or a comment earlier on in the presentation, and we'd like to circle back with you on that if you're willing to come off mute and discuss. Once again, just chat that in if that's something you're willing to do. The same goes for a comment made by Heather Rutherford. Apologies if I got your last name wrong, but those comments about the 50% IA threshold, this is good feedback for us to share with CMS. So please, if you're willing to come off hold, chat that into us. Off mute, chat that into us and we'll go ahead and open that up for you.
Nat, while we wait for them to chat back to us, I want to address Heather's comment about having difficulty getting to the 50% participation rate with the improvement activity for your providers. The improvement activities were built to be broad. They don't have a set of real tight specifications like we see with quality measures. So I see you're willing to come off chat or off mute to talk about this. There may be ways to look at how you're doing that, how you're looking at that improvement activity to show that you're involving 50% of those providers. So I'm going to let you tell us a little bit about that and then we can chat.
Just locating her to take her off mute right now.
Okay.
All right, Heather, you should be able to speak. You may have to take yourself off of mute as well. There is a microphone icon on the bottom of your chat panel.
Okay, Heather, we're still not hearing you. But I encourage you to reach out. I don't know what state you're in. We're going to show you at the end who supports which states. I encourage you to reach out to your state representative to talk through maybe how you can look at and document the work that you're doing to make sure you can get everybody covered. Because I have no doubt that you have done a tremendous amount of work with telehealth and trying to provide quality care to your patients. And even if somebody's maybe not doing telehealth, there may be some things that you can look at. Okay, we're working on the phone number.
Hello.
Hello, Heather, go ahead, thank you.
Hi. So we're a critical access hospital, and we have emergency room providers, surgeons, anesthesia, hospitalists, and primary care clinics. So we are trying to find improvement activities that are impact all of those providers, that make sense for all of them to do, and then could involve 50% of them. One of our barriers is our emergency physicians are contracted with an outside party, so getting them involved at all is difficult, but let alone an improvement activity that would affect equally all these different kind of providers. So we did implement telehealth for COVID. It was quite a rush in all of our primary care clinics and our orthopedic surgeons. However, because we have this big emergency group that filters through here one every couple of weeks, if they kind of rotate through, they significantly are larger than our primary care clinics. So we're ending up, all these doctors are doing telehealth, but not 50% of our providers are, because we have this large group of ER providers that could rotate through. So that is now off of the table, although we did all of this work and we're meeting our patients' needs. That's a little frustrating. We thought about antimicrobial stewardship, doing the antimicrobial stewardship training through CMS, but when we started looking into doing that, the modules that they have to do, and they have to complete all the modules, there's things in there for dentists and for home health and all that stuff. And so the physicians pushed back and they said, I'm not doing the dentist module. I'm an ER physician. Why do I have to do the primary care and the dental module? And I actually opened a task with QPP and asked them, could they just complete the modules that are pertinent to their area of specialty? And the answer was, nope, they have to do all the modules. So it's become very frustrating to find an improvement activity that is impactful for all of them. We don't want them doing something just to do something. We want them to do something that actually is meaningful work. So that's my fun.
Thank you for that, Heather. You have just given us some really good information to be able to talk with our CMS representative about. I don't know that I can give you exact answers, but we will have somebody from our group reach out to talk with you one-on-one to walk through those.
Great.
And you've given us 2 things we can take to our CMS person to talk about how COVID is impacting getting to that 50% in improvement activities, as well as your concerns with the antibiotic stewardship piece. I didn't realize.
Yeah, and then with COVID, if they're not here seeing patients, they're not here.
Meaning the ER docs.
Anybody. So primary care, everybody. You know, we're not having regular meetings. We're not, I mean, they are just not on site. So getting them involved in an improvement activity at this point in time is really difficult because if they're not.
Yeah, the important.
Yeah, everybody's staying away. Mm-hmm. Nobody wants to be at the hospital, right?
Yep, yeah, great point. Thank you for that. I appreciate that. Okay, I saw another question out there. Izumi, and I hope I didn't pronounce your name incorrectly. Will there be a webinar on ways telehealth can be used for MIPS? And I want to address this a little bit. Telehealth is not necessarily distinct from the care that you're giving. So if you are doing a primary care visit using telehealth, you bill accordingly to show that you did that during telehealth, but you can still provide services and gather data that can be used with quality measures and with promoting interoperability measures. So it's not that you have to do something specific or different to make it qualified for MIPS. You just need to look at how that delivery mechanism may change how that, what data you're getting and where that may fit into your MIPS program. Aaron, do you wanna add anything into that?
I was gonna add, this is maybe for Heather, I was actually just typing it out in the chat. If you're still willing to choose a different improvement activity, I frequently recommend the engagement of new Medicaid patients and follow-up as an improvement activity. So if you do see Medicaid patients, there's a couple reasons why I like this one. It sounds like you are in a rural area, and if you are small, it counts for double and it's highly weighted. So all you have to do is 1. And so I really like one. So that's the engagement of new Medicaid patients. And then, yeah, in regards to the telehealth one, yeah, just look to see how you can implement the telehealth in your practice and just apply that to your MIPS. So there's a lot of different ways that can be done, and a lot of good information right now on the internet on telehealth.
This is Miranda. I did want to point out that CMS is putting on a LAN event that has to do with telehealth. So their registration is open. I'm going to read from an email. So if you make sure that you get us your email address, we can send forward you this invite. But it says registration is open for the May LAN, understanding how to implement telehealth services, implications for solo and small group practices. This upcoming event will focus on understanding new flexibilities to the quality payment program due to COVID-19, how to implement telehealth services, implications for billing and participation in MIPS, and tips on how to best modify your practice's workflow. So that is going to be hosted twice, Tuesday, May 26th at 3:30 p.m. to 4:30 p.m. Eastern Time, and also on Thursday, May 28th from 11 a.m. to 12 p.m. Eastern Time. So if you drop your email in the chat box, we can go ahead and make sure that we get, or if you want to email me directly on my email, it's mbrzezinski@mpqhf.org. Sorry, I had to think about that for a second. I can forward you this invite if you'd like to go to a CMS-sponsored LAN about telehealth and MIPS.
We have thank you for that, Erin and Miranda. We have a question from Sarah Gallo. Will QI meetings still count if done virtually? I have seen absolutely nothing that would indicate those QI meetings would not count. What's important is looking in the notes, what's being documented, what issues are you discussing, what actions are being taken. And again, Erin or London, if you want to jump in on this, I have seen nothing that says virtual meetings don't count as towards your improvement activities.
Yeah, I would agree with you, Sharon. I don't think that there's any reason why a virtual meeting would not count, especially everybody's doing things virtually right now.
And you might even want to put in the notes, meeting held virtually due to social distancing guidelines. And boom, that's why you did it virtual. But I would assume that you are doing the same type of agenda, and there's all sorts of stuff to work on right now regarding things like telehealth, regarding what are you doing to start to reopen and start to resume normal procedures, and how do you ensure all of that is staying, you're doing things that keep your patients and your staff safe. That's critical quality improvement work, and I see no reason why that would not count, even if it's done virtually instead of face-to-face.
And there was a follow-up question about the PFAC meetings as well. I know in Nevada we had our PFAC meeting virtually in April, and that's kind of our norm right now is the virtual meetings. And the follow-up question, we were told that HCC codes don't risk adjust on telehealth. Is that at all true?
That's a great question, which means I cannot give you a yes or no answer on that one. I don't know that that I have seen how telehealth affects those HCC codes. And this may be one of those areas where we may see CMS come out with guidance or flexibilities or different information on how telehealth is going to affect the cost category in general. Okay, it looks like we have come to the end of our time together today. We really appreciate your questions, what you're asking, and we're going to take this sort of stuff to our CMS officer that we deal with to give them some feedback from the field. If you think of other things, for example, the HCC codes, risk adjusting on telehealth, if you have suggestions on how you would like to see that work or why that should work, you have rationale on how telehealth is affecting your ability to be able to take care of your chronic care management patients, let us know that. So next thing, make sure to fill out our evaluation that Nat has put in the chat box for us. And I believe the next slide, Miranda, if you keep going, we have contact information for our team members within the states that you can talk with. So Sarah, we see your information about which email list to be on. We can follow up with you and make sure that we get you on the right list so you get the information. Okay, there is our contact information and the different people to contact for the different states. This is for Mountain Pacific. And the next slide will be for CoMagin. And when you get those the slide deck in the mail. You'll be able to have access to all of these, so you don't have to quick try and scribble them down. So thank you for your attention and for joining us today. We really appreciate it, and have a great rest of your day. Thank you.